Dr. Diaz, do you hear me?
Hi, good morning. How are you?
Good morning, Javier.
Morning.
Okay, so we're glad to share your expertise today from Rome. Not Professor Papalia, but Ms. attending, Dr. Diaz, who will talk. So thank you very much. We should start 7:45. We can discuss. Thank you for sharing, for joining us.
You're welcome. Okay, can we start?
Oh yes, yes. Please.
Do you see my presentation?
Yes.
Okay. So, good morning, everyone. I am very pleased to give this talk this morning, and I particularly want to thank Professor Papalia for giving me this opportunity. This morning, I will talk about the fragment-specific fixation in distal radius fractures. This is a very important topic because this kind of fracture are usually due to high energy trauma and involve young patients, but not only. They can be difficult to recognize, and the failure of treatment led to severe consequences. Let's start with some general features about distal radius fractures. They are very frequent in all emergency departments. So in particular, they are the 18% of all fractures in the elderly. They have a typical bimodal distribution in the young adult group related to high energy trauma and in the elderly group. And this influences the treatment attitude. There are a large number of classifications, but no one is really exhaustive. The most used classification worldwide is the AO classification, which distinguishes in type A, which is extra-articular fractures, a type B, partial articular fractures, and a type C, articular fractures. And particularly in the young, highly demanding patient, the surgical indication is given when the reduction is unacceptable according to these following parameters, and obviously if there is an exposure, a neuropathy, or particular functional requests. Today, the most frequent surgical treatment that really changed the history of this pathology is the volar locking plate. In fact, through a volar approach, we can perform an open reduction internal fixation, or IIF, which can result in a very stable fixation with poor risk for the patient, and usually there is no need of implant removal. However, VLP has limits. Although there are the multiple different designs, as you can see in this image for the volar plate, it does not cover all the fragment in a distal radius fracture, in particular in the periarticular ones. As you can see in this image, there are some areas that are not covered with the volar plate. In particular, in high energy related trauma, there can be an important combination of different fragments. These fragments was recognized and classified by Madoff in 2005 and called key fragments. Namely, was major corticular fractures elements that are commonly associated with distal radius fractures, either alone or in any combination. This fragment needs a specific fixation, and this was the beginning of the concept of fragment-specific fixation. And as you can see, the volar plate is not really useful in this kind of lesions that needs a specific fixation. These fragments are the volar rim, radial styloid and ulnar corner, interarticular free fragments or die punch, and the dorsal wall. Now we are going to examine briefly one by one with the most frequent option of treatment. But first of all, let's see how to recognize them. In this image, you can see the original picture in the paper by Madoff. The author showed an X-ray based classification of these fragments. However, this can be difficult to recognize in an X-ray, as you can see in this picture below. In particular, in a less expert radiologist or surgeon. So in high demanding patient or young with an articular comminuted fractures, we can advise to perform a CT scan that can be useful to recognize, as you can see, these periarticular fragments. So one of the most important, most difficult to recognize and most challenging in the treatment fragment is the volar rim. It corresponds to the insertion of the volar capsule on the bone, specifically the two important ligaments, which are the short radiolunate ligament and the volar distal radioulnar ligament. So it needs a fixation because, as you can see in these pictures, if you perform a treatment with a cast or an RIF without recognize it, it can result in a carpal volar dislocation. This for the insertion, this is due to the insertion of the ligaments. So it is very important to fix it. And this can be fixed through a volar approach. And in past years there was used many strategies. First of all, with free key wires or headless screw or marginal plates. The latter are very specific implant, but has several limitations. They are very difficult to implant. They have a high risk of going intraarticular with the screws, and there is a need of implant removal for flexor tendons irritations. Recently, a more specific and less invasive implants have been developed. These are dedicated hooks for volar rim fragments. They can be used alone or associated with a plate if the fragment is bigger. In this intraoperative picture, you can see that they are very, very poor invasive. The radial styloid and ulnar corner are the biggest fragment. They are recognizable with an X-ray, and in this case, you can see the importance of the plate with the variable angle to fix these fractures. In this case, you can see a radial styloid and a volar rim associated, that was the previous case, which have been fixed with a percutaneous screw and a volar rim hooks, obtaining a very good stability with a very poor invasiveness. However, the radial styloid fragment is very crucial because it can hide a scapholunate dissociation. This kind of lesions, as you can see, it can be called trans-stylo-perilunate dislocation. It needs a dorsal approach and an arthrotomy to fix the scapholunate dislocation, as you can see in this picture, using a bone anchor and a percutaneous screw to fix the radial styloid fractures. The die punch or interarticular free fragment does not have any ligament insertion. Thus, it is very difficult or quite impossible to reduce with the concept of ligament axis. So a use of external fixation does not make any sense in this kind of fractures. Often this fragment is impacted. So there is the need to perform a dorsal approach to reduce and restore the articular plane. It can be fixed through a volar manner using a volar plate, as you can see in this case, or if the volar cortex is intact, you can fix it using a dorsal approach. In the case of a dorsal wall involvement, it is mandatory a dorsal approach to fix the fracture. In this case, the patient was operated elsewhere, so we do not have the preoperative exams. However, he presented to us with these X-rays and a very painful and limited wrist operated 1 month earlier. So we asked for a CT scan, and as you can see, there is the dorsal wall involvement that was not fixed with the volar plate. So we reoperated the patient, we removed the previous implant and refixed the fracture through a dorsal approach using an H-shaped plate. Finally, if we have a dorsal and volar cortex comminution, we have to perform a double plating through a double approach. In conclusion, the objective of surgical treatment is obviously anatomic reduction, stable fixation, quick recovery. But not always we can obtain this objective using the volar approach with the volar plate. Also, we have to consider the patient, the age, comorbidities, and functional requests, and consider the trauma mechanism. If we had an high energy related trauma, we have to think and search for the key fragments to fix perfectly the fractures. And the CT scan can be a useful tool in these articular comminuted fractures. So the fragment-specific fixation concept provides the surgeon a versatile and biomechanical stable system to successfully treat the complex interarticular distal radius fractures. Thanks for the attention.
So, Lorenzo, many thanks for this really excellent talk. Greetings again from Bonn. Before we are going to discussion your topic about radial fixation specific problems, I want to say good morning to Denmark. A new colleague has attended our meeting this morning, Per Gergers Andersen from Vejle. So Per, many thanks that you are in the phone and that you are incorporated in this new format of Europe-wide, let me say it like this, Europe-wide educational platform.
Thank you, Dieter, for the kind invitation. I will, of course, do my best to have my department to participate in these sessions. But first of all, today is my first time to be together with you, and I will try to take advantage of your educational tools. Thank you so much, Dieter.
Yeah, as I see, as a past president of EFORT, you have done sports this morning.
Ja, das ist natürlich, weil ich ein Sportsfreund ist.
Okay, so Christoph is now overtaking for discussion.
So, Lorenzo, what's your specific fixation system you use? Is that your own? What the company, what the implants? They do not have those special hooks.
I'm sorry, I hear you very bad.
The hooks you use for specific fragment fixation, what the company you use? It's not Zintis, ni Königs, neither any company I know. It's your own concept? Do you use your own implants?
Yes, yes. Yes, I use when there is indication, I use these implants alone or in association with other implants, if this is the question. I hear very bad.
Okay, so Javier, Fernando, Paco, do you have objections? Discuss it with our
No question from Madrid till now.
Do you have the same possibilities to fix the most common fracture in humans, 25%, distal radial fractures? Everything clear? No questions? So, okay.
Lorenzo, I
Yes.
have one question.
Good morning. Do you hear me?
Good. Yes, quite bad.
Quite bad. Okay.
But let's try.
How many percentage of your fracture is from dorsal or combination or just from palmar side?
Yeah.
So,
Do you hear me better?
Lorenzo, do you hear me?
Yes.
It's Thierry from Paris. Are you using sometimes a dual approach, volar approach and dorsal approach, just to fix on the volar side and on the dorsal side? And
Yes.
what is the percentage
Yes.
of cases you are doing
Yes.
this?
You can, if you have, for example, a free articular fragment, you can use the dorsal approach to fix and reduce the fractures, and then you can use a volar approach to do the fixation and perform a volar plating. So you can use a combination of dorsal and volar approach and fix and implant through a volar approach using the volar locking plate. The dorsal, you have to use the dorsal approach and to fix the fracture and implant the plate dorsally if you have basically an intact volar cortex. Because as we can see in the case, if you go through a volar approach to fix a dorsal wall fragment, you can fail to do the fixation.
okay, thank you, Lorenzo. Two things, the new website, quarter two, we send it to you all. So we are recording the talks. Everybody agrees to have available all the talks from now, once a month. This is our objection from now. The next presentation, I think, it will be given by Fernando Marco, Madrid, the University of Madrid, and we have the last Thursday in June, 24th. We see you. The topic, we'll send it, we'll put it in the website soon. So we are trying to gather more countries, the countries in the EU with the same time zone. Great Britain is too early. They don't want to share us live, but everybody can see and upload and download the talk. So see you in 4 weeks. Thank you for joining us. Goodbye. Paris, Madrid.
Thank you.
Okay, goodbye.
Bye-bye. Thank you, everybody.
Bye-bye.
Goodbye.
Thank you. Goodbye.
Thank you, Lorenzo.